Well, it is my pleasure to introduce today's speaker, Dr. Erin Light. Dr. Light is the Dean of Health Sciences at Ozark Technical Community College and previously served as the Respiratory Therapy Program Director and Director of Clinical Education for 18 years. Dr. Light's 15 years of clinical experience was primarily in the adult intensive care units as well as emergency room. So we are real excited to welcome Dr. Erin Light.
So hello, everybody. Thank you for coming and listening to this talk. With this talk, she's already spoke a little bit about me and who I am, but I want to go ahead and talk about any other potential conflicts. I do work for Ozark Technical Community College. I'm also a new faculty member at UNC Wilmington. I'm a former faculty at Northeastern University. I'm a current Missouri Society AARC delegate and former AARC Board of Directors member. And then really don't have any other conflicts of interest to disclose at this time. So with this talk, when I was asked to do this talk, it was about critical thinking and in the ICU and how do we need to do it? How can respiratory therapists become more adept at being able to do it? And for me, one of the biggest things is I can provide cases after cases, but then you'll kind of learn, okay, in this case, I do this scenario. And it's not really teaching you how to critically think. So I'm going to be talking more about what is critical thinking, what are the barriers to it, and then using cases to demonstrate where those barriers cause the problem for somebody being able to critically think. So when you look at critical thinking, a lot of times you'll see in text, and when you look at academics, they'll try to break it up between an analytical thinker and a critical thinker. An analytical thinker is a person that uses logic and critical thinking to analyze the situation. They break down the problem into small solutions to find parts. To our critical thinkers, defined as a person who makes reasons, judgments that are logical and well thought out. Well, to me, these are very, very similar. But what it really is that critical thinker is looking at things in more of a holistic and kind of round the entire situation versus the analytical thinker is trying to move from one particular step to the next. So that analytical thinker is much more linear and focused, to where that critical thinker is trying to look at the problem at hand and working its way all the way around it to determine what is the best solution for it, versus just moving, okay, I need to go step one, okay, I need to go step two, then now I need to go step three. That's more of that analytical, versus the critical thinking is trying to get a broader view in and around it. And a lot of times when people think about critical thinking, or they hear some other lecturer talking about it, or they hear their boss say, you need to be a better critical thinker, learn to think outside the box. To me, that's a little bit of a misnomer, because thinking out of the box is a lot of times thinking outside of the normals, thinking beyond what we know is a possibility. And that's not really what critical thinking is. Critical thinking is taking all the evidence that is in and removing all my potential biases and barriers and being able to put it together with what I know, not necessarily being that creative, crazy, outside the box thinker. That's not really what critical thinking is. In my opinion, it gets really misconstrued on that, that you have to be this outside of the box, creative, crazy person. But when you look at critical thinking, there's barriers that can arise. There's an over-reliance on feelings or emotions, and this can happen to us internally. The emotions that we might have with a patient, the emotions that we might have with a fellow care provider. Are we angry at them? Are we friends with them? Are we not friends with them? That can be a barrier to our ability to think. This self-centered one, cultural-centered thinking one, to me is much more about that conformism of it and the peer pressure that we receive in ICUs. Are we going to conform ourselves to how that hospital thinks, how that hospital views things, how my fellow respiratory therapist or the nurse I'm working with or the physician I'm working with, am I conforming to their thought? And if I am, I'm really creating a barrier to critical thinking, because now I'm not thinking with all the data. I'm just thinking of, okay, this is what I know you want, so here you go. There's also unconscious bias, selective perception. So these are things that are inherent to us that make it to where we unconsciously make determinations and decisions that may not be in the best interest of our patients. The next one, inability to receive an input, a view that's different than ours, closed-mindedness. To me, this is a lot of ego-ness. And a lot of people in healthcare, we have this issue, we have this problem, we have this ego that my opinion has to be the right one, or my opinion is the right one. I know better than you, and so I'm not even going to listen to your thoughts and your opinions. And that is a problem, and it's going to make it to where we're not going to be effective critical thinkers. Unwarranted assumptions, or for me, the biggest one is a lack of relevant information. You didn't ask enough information. You didn't ask for enough data. You didn't go search out the data to be able to effectively think through the problem. Fear of being wrong. This can happen to a young clinician or an old clinician. Nobody wants to be wrong. Nobody wants to make a mistake, but having that fear is a barrier to us being able to critically think. Poor communication skills or apathy. Apathy is a thing right now. If you look at a lot of the literature that's coming out in all the healthcare providers, whether it be respiratory, nursing, physician, there's a lot of burnout. Burnout and apathy are very closely associated with each other. So apathy can make a barrier to critical thinking. And then lack of personal honesty, that's kind of another ego thing of, are you really looking at what you think is right, or are you looking at all possible options? So that's kind of barriers. Now, I also want to point out what critical thinking is not. It's not knowing all the answers. A lot of times people are going to think that, oh, the person with all the answers, they're the best thinkers or the best critical thinkers. Not really. That's not the case. And most of the time, those people don't know all the answers. They just have a group of friends, or they have a way to research the problem to find the answers in a more efficient and effective manner. A lot of times people think too, also knowing all the fancy stuff. That's critical thinking. It can't be that simple. In my experience, knowing your basics, most of the time it is that simple. Remember what you learned in school. The fancy stuff is there and it's great, but remembering the basic, remembering those foundations, most of the time will get you through the problems and get you through to where people are like, oh, that's a great critical thinker. It's just you were focused on the basics. Creative thinking isn't necessarily always a critical thinker. They're thinking of that creative idea that's going to wow everybody in the ICU. Like, man, how did they come up with that? That's not really critical thinking. That's creative thinking, but it's not necessarily critical thinking. To me, also protocol thinking is not critical thinking. Protocol, I've taught classes on how to write protocols, and it's step one is this, step two is this, step three is that. It's kind of a recipe-based healthcare type model. That is not critical thinking. That's just providing the pathways for a person to work through a series of problems. And normally at the end, there's a, if this doesn't work, seek additional support and help. That's when the critical thinking is actually going to come into play. Protocol thinking is just going to go through the most obvious options. So what are the basic steps? Identify the problem, establish the facts, evaluate the logic in it. Notice I didn't say evaluate the research specifically, but a lot of times it's evaluate the logic. Does this make sense? Does this make sense from a physiologic sense? Does this make sense just from a physics sense? Since we deal a lot with airflow, blood flow, things like that, physics comes into play. And then from that, now I get to actually make a decision. But the hardest thing that I think people have with the basic steps is honestly just identifying what the actual problem is. What is going on here? And so here's an example of it. So this was a case, this was a real case. Patient started fighting the ventilator. In this particular case, it was a VDR. So fancy ventilator, whether you want to go, it works, doesn't work, doesn't matter. They're on the VDR. The patient, all of a sudden, they were doing fine and started fighting the ventilator. They're bucking the ventilator. The SpO2 drops, the heart rate's going up, work of breathing's increase. There's this doom and gloom kind of emotional response felt by the clinicians in the room because the patient's chest isn't rising. It's not showing that expansion of the chest wall. So they're like, okay, they're not getting enough air. Patient is doing poorly. And one of their initial responses is, okay, we need to change out the vent and get a different vent. It must be the VDR. And then one of the other responses was actually they were calling the doc to come put in chest tubes because they're like, hey, we're not hearing a lot of air movement. There's not a chest rise. I think this patient has a pneumothorax or a hemothorax because it was a trauma patient. So they're like, that has to be the reason. Another therapist happened to be walking into the room and simply asked, what happened before all this started going on? And while they ask that question, they're going over and they're looking at the VDR and they're looking at the patient and they're like, what? Like, what happened before? They were doing good. Now they're not doing good. What happened? And the nurse goes, well, I went in there to suction because I had a lot of secretions in there. So I went in, I suction. And then all of this started happening. The heart rate went up. They couldn't breathe. So I called the therapist. The pulse ox was dropping. They raised the FiO2. And it's the vent. We need to get rid of the vent. About that time, the therapist that walked in to ask the question, what happened before all of this, looked down at the ET tube, pulled out the Ballard suction catheter, and goes, pulled it out. Now all of a sudden the VDR could get air down into the lungs. The chest went back to rising, doing its vibrations like it does with the VDR. Chest movement occurred, SpO2 went up, heart rate decreased, work of breathing decreased, and the patient's not fighting the ventilator anymore. So is this crazy creative thing of critical thinking? Or was it just what happened? What's the problem? And come to find out what the problem was is the Ballard was down the ET tube, causing a high amount of airway resistance, and the VDR couldn't ventilate the patient. So in this case, what was the barrier? Lack of relevant information. They didn't bring into effect that what caused the problem was a suction, and oops, the Ballard was still down the ET tube. And what also occurred to cause barrier to critical thinking here? Poor communication skills. The clinicians at the bedside weren't asking the right questions to figure out what the correct fix would be. So how do we avoid these barriers? Well, we want to make sure that we're not having what is that confirmation bias, where we're only looking for information or other people that might prove my opinions about what the issue or problem is. So I'm not going in going, okay, I know what the problem is, because then at that point you are looking for information in the patient and the ventilator that is going to prove your hypothesis correct, versus going in and looking at going, what is the data, what's going on, what's the exact problem. So that confirmation bias is a problem in the ICU. It's a problem in research when you're going to do research on a particular problem. If you're going, I know what the problem is, and I'm going to go get the literature and prove you wrong. I'll guarantee you what you're going to find is evidence that proves your case. Problem is the person that you might be arguing with went and did research on the other end and found conflicting evidence. So when I teach research courses, I always tell them, I was like, go find the evidence, and then purposely you're going to have a thought. We're humans. We're going to have an opinion. Now try to convince yourself you're wrong. And what I'm trying to get them to do is stop having confirmation bias. And the way you can do that is try to prove yourself right and try to prove yourself wrong. Self-serving bias is another problem. What is best or easiest for you? Patient on the floor calls for a treatment. The easiest thing for me to go in and do is just let me give you the treatment so I can get on and move on my way. But it means that I may not be fully assessing this patient to determine why do they need the treatment? Do they need something different? Because the easiest thing is just to go in and do the therapy. So we have to make sure that we're not doing a self-serving bias. Normalcy bias. Well, others do it. I've always done it that way. We've always done it that way. This is a normalcy bias that we need to make sure that we do not have in the ICU. Well, we've always done it this way, so it has to be correct. No, it doesn't. All that means is you've always done it that way. That to me is one of the biggest telltale signs of a problem. When one of the first things somebody says to me is like, well, we've always done it this way. That tells me they're not critically thinking. They're not looking at all the evidence to determine what might be right or wrong. Another one, availability heuristic. This is basically meaning that the first piece of information rules them all. So the first thing I see has to be what the problem is, or what is the most easily seen information has to be what the truth is. That's availability heuristic, excuse me, can't talk this morning. And that is a problem in the ICU, because a lot of times the first piece of information isn't what the problem is. It was just the signal to tell us that there's an issue and a problem. So let's go through and we'll start kind of working through some cases, because those are always much more entertaining than talking about the theories of critical thinking. So we'll use this one here. This is case one. This was a real case. This was one that happened to me. I got a phone call. There was a 58-year-old female in the ER. And they're like, Aaron, get down here. Pulse ox is 78 to 80%. I think we're going to have to put her on a BiPAP or intubator. Get down here now. And I'm like, cool. So I went running down to the ER. And when I walk into the patient's room, I see the patient. She's sitting there watching TV. Legs are kind of up on the little stool. No respiratory distress whatsoever. She is on a 2-liter cannula. I asked her, I'm like, hey, do you use that at home? She goes, yep, I use it all the time. I'm like, okay, so you're an O2 dependent patient. I look, respiratory rate was about 20, 22. Heart rate was about 100, 105. Her color was normal. Her work of breathing was normal. I asked her if she was short of breath. She said, nope. And I mean, this whole time I'm also looking up at the monitor, and I'm seeing the pulse oximeter. It's saying 80%. There's a good pleth. It's there. I went ahead just to play with it, wanted to put it on a different finger, put it on a different hand. Each time, good pleth, reading SpO2 of 80. And I'm like, that's odd. Put it on myself. It was popped up into the 90s. So I'm like, okay, the pulse ox seems to be working, but that pulse ox doesn't necessarily fit what I'm seeing. So I went to my doc and I went and had a conversation. I'm like, hey, what's going on with bed 22? Doc's like, man, I don't know. I think we're going to have to put her on BiPAP, intubator. What do you think? Luckily, I knew this doc really well. And I was like, I don't know. Have you seen the patient? And the doc was like, are you telling me to assess my patient before I call you? And he was smiling. Once again, we knew each other. And I'm like, yes, sir, I am. He's like, well, Aaron, he goes, you need to see the blood gas. I'm like, okay. So I was like, what does the blood gas look like? And he showed it to me. It's 735, 43, 48, 25, and sat at 83. And I'm like, whoa, okay. Thing that sticks out to me, probably stuck out to everybody else. PaO2 of 48. And sats on the gas were about 83, about 81, 83. I'm like, okay, still doesn't make sense. If this patient was truly this hypoxemic, why is she not showing signs of being hypoxic? Her respiratory rate should be up. Her work of breathing should be up. She should be confused. None of those signs are there. Plus, her CO2 should have been lower because she should be hyperventilating trying to get the PaO2 up. Like, it doesn't make sense. I was like, are we sure that maybe some venous blood? But I was like, even if it was venous, I would expect my CO2 to go up. And he was like, Aaron, he goes, I was in there. It was a good draw, felt good. He's like, it was a good draw. I'm like, still doesn't make sense. So I'm like, all right, let's go back to the basics. Patient hypoxic or hypoxemic, but not demonstrating hypoxia. So I was like, have we done a CBC on her? And he goes, well, yeah, why? I'm like, can I see it? He goes, yeah. And then he gets shown to me and the hemoglobin was 18. And I'm like, good, we're done. He goes, no, Aaron, PaO2 is still 48, patient sat in the high 70s, low 80s. We're not done here. And I'm like, yes, sir. She has a lot of buses. She is just fine from an oxygenation standpoint. And he's like, I don't understand. And I was like, PaO2 is the oxygen that is in the plasma. Saturation is now telling us what is on that hemoglobin. She has a lot of buses. They don't need to be 90% filled because she has more buses carrying oxygen to the tissue. And it's obviously getting to the tissue because she isn't showing signs of being hypoxic. So this patient is fine. And he goes, Aaron, that doesn't make any sense. And he goes, I don't know what you're talking about. So once again, not thinking craziness. I'm thinking about, remember the basics. O2 content. Hemoglobin times 1.34 times saturation, PaO2 times 0.003. Did it all up, wrote it all out, said her hemoglobin is 20.16. Normal is 16 to 22. She has a normal amount of oxygen in her blood. You cannot say she is hypoxemic. She's got a normal amount of oxygen. He's like, I still don't understand. I'm like, fine, let's do me. So I went ahead and calculated mine off of some assumed values. I didn't go blood stick myself. And so I used PaO2 of 90, sat at 97, hemoglobin of 16. Lo and behold, my O2 content was 21.07. Pretty dang close to this patient that he was getting ready to admit for hypoxemia. Remember your basics. This isn't anything creative thinking. This is just looking at the data from all surrounding facts and coming to a conclusion. Now, unfortunately, this particular patient ended up getting admitted for hypoxemia because that's what they had. They had a PaO2 of 48. The ER doc was like, I have to admit them. PaO2 of 40, or I have to do it. Admitted her 2 days later. She ended up going home because the hospital is going to find any reason to keep her there. So what was the barrier to critical thinking in this situation? Conformism. The doctor was conforming to the situation that if a patient has this singular value, I have to do this. Didn't have that full information. So when I got the call from the ER nurse and she's flipping out, didn't have all the data, i.e. the hemoglobin 18, and then the doc was afraid of being wrong. That prevented the critical thinking situation from arising, even though the data showed this patient is just fine. Move to case 2. 65-year-old male admitted for dyspnea and COPD. Patient shows that the respiratory rates of 22 to 26 through the day. This was a real case. I was brought in after the fact to review it because somebody ended up getting written up for their actions in it, so they asked me to come take a look at it. But this was how the patient presented. 65-year-old COPD, admitted for dyspnea, but now they got respiratory rates of 22 to 26 through the day, been pretty stable, and then all of a sudden things weren't stable anymore. RT was called into the room to assess because the SpO2 was 83%. Patient now presents with a respiratory rate of 35 breaths per minute, heart rate of 120, accessory muscle use, prolonged expiration. We've all seen this patient. They're on a 28% Venturi mask. So the therapist goes over there, turns up the O2 flow rate on the mask, and now the patient's SpO2 is 91%. And they're like, okay, I fixed the immediate problem, which was hypoxemia. Unfortunately, whilst continuing to watch the patient, the work of breathing, the high respiratory rate, the tachycardia, the prolonged expiration didn't go away. So we all know, okay, breathing treatment, steroids, or BiPAP is what we need to do. And because the dyspnea continued, the floor therapist requested the patient be moved to the unit, placed on a BiPAP, increase their steroid dose, move the breathing treatments to Q4 instead of a PRN. Let's take care of this work of breathing and more than likely a bronchoconstriction situation. The physician denied the move request, physician denied the BiPAP request, physician denied the steroids. We did approve, go ahead and give a couple extra PRN breathing treatments, which the therapist did, went ahead and gave the treatments, continued to monitor the patient. 2 hours after all of this initiated, the patient continued to have increased work of breathing, tachycardia, tachypnea, was now becoming lethargic, but the SpO2 remained at 91%. Patient ended up being transferred to the unit and intubated. This is where the problem came up, is the floor therapist was written up for knocking out the hypoxic drive and causing the respiratory failure. This is where I ended up getting called into the situation to figure out, hey, what is going on here? So when you look at it, the patient was on a Venturi mask. So Venturi masks normally set up have an inspiratory or an expiratory flow rate of about 30 liters per minute. Normal inspiratory flow rate for a normal person breathing is about 30 liters per minute. Well, as soon as that patient started taking bigger and deeper breaths and working harder to breathe, their inspiratory flow rate went up, which means now they're entraining more room air into that mask, and that dropped the amount of oxygen that they were actually receiving. Now, the amount of oxygen coming out of the Venturi mask never changed, but the amount that they received went down because they were breathing deeper and faster. So what are some situations that therapist, they're saying, hey, when he increased the flow rate on that mask, it knocked out the hypoxic drive. You gave him too much oxygen. By you raising it up, you gave them more oxygen. The FiO2 coming out of the mask was unchanged. It was still 28%, which was what was prescribed by the physician. It was 28%. The only difference was it was 28% coming out faster. And knowledge, basic understanding of the venturi mass would tell you that the FiO2 didn't go up, the total flow went up. What didn't change? SpO2. The patient had been around 90 to 92. In this situation, after the therapist turned it up, was still in that 90 to 92 range. So even if you believe in the hypoxic drive theory, didn't knock anything out, because that would be 88 to 92. We're always trying to keep those COPD patients. What didn't change? Respiratory rate during the entire time from when the therapist first stepped into the room to when they intubated, the patient was breathing in the mid to upper 30s the entire time. So if you had knocked out the hypoxic drive, the respiratory rate should have dropped down. It did not. The patient's work of breathing did not change. So how can you come to the conclusion of knocking out the hypoxic drive when the patient was still breathing like a freight train, working hard, the SpO2 was only 90 to 92, and no more FiO2 was given than what they had been previously on? Doesn't fit knocking out of the hypoxic drive. The therapist was not at fault here. So what did happen, more than likely, is the patient tired out because they were working hard to breathe, and what they needed is something to reduce their work of breathing. Remembering what we talked about before, the key problem is identifying what the problem is in the patient. And in this particular case, the problem was the increased work of breathing. So that excessive work of breathing wasn't being caused by the hypoxemia, because we fixed that when the flow rate was increased on the mask. SAT's 88 to 92. Wasn't the hypoxemia, it was something else going on in with that patient, and non-invasive is indicated for a patient with increased work of breathing and COPD. So that was the problem, and that problem was never addressed. They focused on the oxygen because what started the whole situation? The drop in SpO2. And so that's what all the caregivers were looking at, is that drop in SpO2. So this must be the problem. And then when bad things happen, it's like, oh, well, we gave them too much oxygen. That was never the issue and problem here. The issue and problem was that a high work of breathing, which was never addressed with the non-invasive. So what were the barriers to critical thinking here? Conformism, dogma, peer pressure. We all have those people that believe in the hypoxic drive, and it's got to be true, and you're going to knock it out. You can't give them too much oxygen, and they just press and press and press. So you start to conform to believe that this must be an issue and a problem, which then creates an unconscious bias, and you now start to have a closed-minded to what other possibilities might be at play here because of that conformism. There's also unwarranted assumptions being made that, oh, it had to be because of the oxygen, because you turned that flow meter up, and you can never touch the flow meter on a COPD patient. You can touch the flow meter on a COPD patient. You can have them on 100% oxygen. The key in all this is, even if you believe in the hypoxic drive theory, which I'm going to talk about in a minute, it's still about the amount of oxygen in the blood. And in this case, it was never elevated enough to create the problem. But quickly, to go through some literature on hypoxic drive theory, on why it's a myth, I went back and looked. The first thing I could find was all the way back to the 1960s, an Atlantic article that talked about hypoxic drive and worries with a COPD patient. So we're talking, what, 60 years ago is when this was kind of first brought up. In the 80s, 20 years later, people started actually finally researching it and finding out that, you know what, it's not the case. And this one, from 1980, increase in PaCO2 was found to be due to dead space change, not ventilator. So there was no knocking out of the hypoxic drive. So with this going back, 1986, another study was done. No one stopped breathing. There was no connection between PaCO2 and ventilation found. This was back in 1986. Here's another one, 1987. Study suggests hyperoxemic induced hypercapnia in patients with COPD is not primarily related to hypercapnic or hypoxic drive. So hypoxic drive was kind of ruled out on this one in 1987. 1997, oxygen-induced change in ventilation observed is equal to that expected from ventilatory drives and changes in PaCO2, and once again, not from them having their hypoxic drive knocked out in 1997. 2002, so we're still doing it 20 years later, still looking to see, is the hypoxic drive true, because people are still believing it. 36 patients recruited into this particular study, and what they found out is there was no significant difference between the two groups in the main outcome variable or poor outcome, which would be mechanical ventilation or death. So it was not found. There was no difference in hospital stay, no difference in PaCO2 or pH when the patient got high amounts of oxygen or lower amounts of oxygen. So even in 2002, still not 20 years worth of studies all showing giving a COPD patient oxygen does not knock out their hypoxic drive. There's quite a few additional studies on this, but unfortunately, yet schools still teach the knocking out of the hypoxic drive. Clinically, you get told by physicians, nurses, and other RTs can't give O2 to a COPD patient. That's a problem, and it is not supported in the evidence. Most of the time, it's due to some unicorn situation to where they're like, I had a friend who had a patient who they put him on oxygen. As soon as they put him on oxygen, they stopped breathing. There was some unicorn, and I bet you if we went back and we looked at that case, there was another reason for it, because all the data shows that the knocking out of the hypoxic drive is not a true thing. So for me, I added one thing to the critical thinking can arise through. I added one. School is telling students that articles older than 5 to 10 years are not relevant. To me, that is a part of the problem, because it might have been that, hey, back in the 80s, we proved it's not true. But if you went to go research it now and your school said can't use anything more than 5 to 10 years of age, you're not going to see all of those. And so you're going to think, oh, well, there's no evidence out there. No, it's just that the evidence was done so well so long ago, nobody's been needed to repeat it. I never had that 5 to 10 year rule on relevance of data, because I think you have to look at all the data to be able to figure it out. But back to actual cases, which are a whole lot cooler to deal with. You have a 27-year-old woman comes to the ER complaining of pleuritic chest pain. She takes birth control, otherwise no meds. Chest x-ray and physical exam are normal. Most of us, if we were the therapist walking in, we're like, yep, and I'm out. For this reason alone, I'm out. There's nothing here. We're good. There's no wheezing. There's no hypoxemia. Why am I here? I'm out. This particular physician, and this was a real one as well, was a newer physician, actually got a blood gas on this individual, showed it to me, and it was 745, 31, 21, and 83. So now we have a patient that has a slightly alkalotic pH, slightly alkalotic CO2, bicarbonate normal, PaO2 is normal. So most people would be like, oh, they're just hyperventilating because they had a blood gas. They're fine. However, if you, once again, you remember your basics, because the easiest thing to do, and that's one of the reasons that people don't critically think, the easy thing is to walk out and say the patient's fine. But remember your basics. Here, just do a simple PF ratio, you're going to go, oh, it's normal, it's 395. See, I took an extra step, I'm good. However, the thing that was kind of intriguing is this particular patient had a big AO2 that was 110, and when you did the AA gradient, that AA gradient, which is the difference between the alveolar oxygen level and the arterial oxygen level, was actually 27. Now that gradient increased due to CO2 changes by the patient. So the reason that that happened is the patient was hyperventilating, and now that's why that PaO2 is up. And if we remember, normal AA gradient is 5 to 15 in a normal patient. This person was almost double that, and in some cases was 6 times that. So there's a problem with getting oxygen from the alveoli to the capillary bed, as evident by the AA gradient. So what ended up happening, they ended up doing a CT scan, demonstrated pulmonary embolism. And if you remember from the original part of the story, birth control pills, well, birth control embolism is about 3 for every 10,000 people. And while the rate is low, given the large number of oral contraceptives users in this country and across the world, the possibility of this occurring is prevalent. In this particular case, the patient had a small little PE, and that is what was causing the pleuritic chest pain, and that's what was also causing the increase in AA gradient. But many of us would have walked right past this particular blood gas and never honestly done any further investigation. Myself included, I probably would initially look, yeah, it's fine. But it is kind of weird. PaO2 of 83, room air, CO2 is 31. Hey, it really should be higher than that in this particular patient. So barrier on this one was just lack of relevant information. They didn't go down to the level of getting an AA gradient to see what the issue and the problem was. Here's one of my other favorite ones. This was actually a post on Facebook, so this was real. I love Facebook. I love being a part of RT groups and ICU groups because I see cases and they're entertaining. This one was, we drew a blood gas on a 30-year-old male responding to a rapid response for a seizure. The first gas was 7.04, CO2 at 33, PaO2 at 244, bicarb at 37, no air in the sample. Second gas was drawn after given a liter of fluid, and now it's 734, 38, 107, 22. The question was, how can this be? How can there be this big of a turn in 1 hour after giving a liter of fluid? Can somebody please explain? And so for me, not even getting to the comparison of the two gases, I was fixated on the 704, 33, and 7 on the bicarb. And I'm like, those just don't seem to be adding up to be making sense. Yes, the patient should be acidotic, but it seems to be that they should be a little worse off than the 704. So once again, remembering the basics, I was sitting there going, well, let's check to make sure that these numbers are correct, because somebody can fat finger things on Facebook, can make mistakes. And lo and behold, when you use the HH equation, which by the way, I don't go through and calculate it. I've got a website that I go to and I just punch in the numbers and it does it, because I don't like using logs. But that's 704, 33, and 7. If that bicarb is 7 and the CO2 is 33, the pH should have been 6.95. So my answer that I put on there is, the answer is that we can't really do anything with this situation because the numbers are not valid. I'm not going to give you an opinion on what caused the difference between gas 1 and gas 2 if the data itself is not correct. So on this one, I was like, ignore the gas, ignore the situation until we have correct data. Responses I received after I made that post was, you're wrong, I've seen a pH that low before. Please remember, I didn't say the pH couldn't be that low. I was just saying that it has to actually be lower given the current values. Another person, you can't calculate the pH, it's a reported value. I've seen this very gas before, you don't know what you're saying. I've been in RT for 30 years and that gas is very possible. And then one person was like, look at all the other responses. Everybody else is saying this is possible, i.e. you're wrong, you're stupid, you don't know what you're talking about, because everybody else agrees with me. Those are all cases and presentations of barriers to critically thinking. Nobody actually reported and looked at, hey, is he correct and wrong on what the pH should be? They were all more personal attacks or pulling from random experiences, and those are all barriers to being able to critically think. So they were all conformism, inability to view an idea that is different than mine as a possibility, and also, truthfully, a lack of relevant information. They obviously didn't remember the basics of the HH equation. And so what do they respond with? Has to be wrong, can't be right, no way, you're an idiot. Because they have barriers to critically thinking. So is this equation still needed in clinical practice? Yes. Did I go around doing this on a daily basis? No. It was just when I saw things that were like, that doesn't quite look right, I would go into the HH equation. I'm going to do one more and then I will stop for questions that people might have. But here's an actual blood gas from a local hospital. 716, CO2 of 77, PaO2 of 316, bicarb of 27.8. Student brings this in and goes, here was the gas. And I'm like, cool, let's first take a look at it and let's analyze the data. For me, this was an acute respiratory acidosis, 716, 77. The student was like, well, but this went out of range. I was like, it only went out of range because of hydrolysis. There's no real compensation going on. Every 10 rise in CO2, you're going to get a 1 rise in bicarb. And so this went up about 35, so this should have gone up about 4. Hey, take 4 away from this, we're in a completely normal range. So there was no compensation. This was purely an acute respiratory acidosis. They ended up intubating the patient. Now we're at 755, 26, 51, and 20, and the confusion was, how did the bicarb go down by so much, so fast. They're like, bicarb takes time. It wouldn't have gone down that fast. What's going on? Hydrolysis. Look at your CO2. It's 26. It was 77. So more CO2 in the blood creates more bicarb. When you got rid of all the CO2, now it's 26, your bicarb is going to drop, and it's a mathematical equation. Hydrolysis is much more than didactic ivory tower stuff. I get told all the time, well, that's an ivory tower, they use an academic. It's much more. There are clinical, this is a real blood gas that was causing confusion that was 100% due to hydrolysis. So I want to kind of kick to the end here. So to be a critical thinker, what do you need to avoid? Avoid confirmation bias. Avoid self-serving bias, which is what is the easiest for you. Avoid that normalcy bias where you're sitting there going, well, this is what everybody else is doing. This is what I've always done. Those are all barriers to you being a critical thinker. Make sure that you avoid those types of things so that you don't get into those particular situations. So with that, I'll end with my dog and my cat. Yes, they do actually love each other this much. He uses her as a headrest all the time.